Starting off, one obviously obtains cardiac arrest in the patients, and my recommendation is antegrade cardioplegia if you can, and then retrograde, and try and avoid pleging the coronary ostia as much as possible. Obviously, if you have severe AR, you have to. So there's the first part of putting in the atrioventricular vent. Make sure you don't perforate the left ventricle with that, and be gentle with it and keep it in just beyond the mitral valve. I then start off by putting sutures just above the right ventricular outflow tract for retraction, and then another one typically of silk for the fat at the right coronary artery ostia. Then transect the distal aorta, and this is a patient whose brother had operated on with Loeys-Dietz, and there you see the dissection plane of the disease, and the root here is a bit smaller because it's a Loeys-Dietz patient. Notice the bleeding from the conal artery or conal arteriovascular. Critical that you preserve that, otherwise you can have problems with ventricular tachycardia or fibrillation at the end of the operation, and occasionally I've had to even bypass that vessel to get the patient out of ventricular arrhythmia. The right button, I usually put a suture to retract it, but stopped doing that for the left button after I had a patient who developed dissection of the left main from the traction suture, so I don't do that any longer. Notice also I don't use balloon catheters into the coronary ostia after having had dissection from that. So the next step is then to put the commissural plegited sutures into place to put tension and keep tension on the commissures. The critical part of this operation, as with the bicuspid remodeling operations, is tension on the commissures and thus on the leaflets. So once those three are in place, then you get a better idea if this is going to be a competent valve, and obviously you will check to see that there are no major bad perforations. The next step is mobilizing the valve to below the annulus of the valve, and I usually use cautery at a setting of 25 to mobilize the valve. In patients with connective tissue disease, the depth of the right cusp often goes quite far down and below the right ventricular outflow tract, and that can make it a bit tricky, but the way to get around that is to put the needle threaded through the aortic wall in those areas. Now here at the left to right commissure, it can often seem that there's no plane, but you have to keep on going and get through this area. I've noticed some people don't get through this, and then you just don't end up being deeply enough below the annulus. And the trick here is, as you work through this, what does not seem like much of a plane between the pulmonary artery and the aorta, you'll start seeing a sort of browner area of tissue after you get through the fat pad. So first you've got to separate the pulmonary artery from the aorta, and then you'll get into a little fat pad, and then you go below and into that fat pad until you get this sort of brown muscular kind of tissue. It sort of goes brown once you cauterize. But as you can see here, this can be a bit of a tricky plane to get through, but you have to get through it. Just trust me, there's a fat plane underneath this that you get into, and then you know you're getting into low enough below the annulus and making sure that you're going to get that whole valve into the new tube graft. there's often two little veins here, one running around the base of the annulus towards the left leaflet, and the other one here around the right sinus leaflet area. And then keep on going to make sure that you get deeply enough so that your graft is going to end up being below the annulus. Now, in my early period, I certainly bowed into the various structures around here, whether it was right ventricular outflow tract, right ventricle, left ventricle, left atrium. And there you see the valve now nicely mobilized, good leaflets, and now you start putting those sutures through the left ventricular outflow tract below the annulus. So I will typically put 2 sutures between each commissural suture for each sinus, except for the right ventricular outflow tract. And that leaflet typically is longer, and certainly at the annulus, and so there I will put 3 sutures. The other reason is that most of the time when there is a severe regurgitation and leakage, it's because of the right leaflet prolapsing and causing regurgitation. So there you see those sutures being put into place. I tend to, for the left-right and the right non-coronary, to come up a bit underneath the commissure, but for the non-coronary left, I tend to stay in a fairly flat plane. And here now the 3 sutures that will go under the right leaflet, and you notice I'm taking my time threading that needle in the aortic wall there. You don't want to get into that right ventricular outflow tract, because then you're going to have bleeding from the right ventricular outflow tract, and that could be tricky to control at the end of the operation if you end up with a perforation or fistula or leak from the right ventricular outflow tract. So just skim along the aortic wall and try and keep that suture in the aortic wall. So then I mark the tube graft. Most of the time I use a size 30, and I mark where the anchoring spots are going to be for the right leaflet. Then those sutures on the commissures are fed through the tube graft, and then we start putting the sutures through the graft, probably about 4 millimeters apart on a 30 millimeter hemostasis graft. I don't use the Valsalva graft, and partly because there's some evidence from the Hanover group that regurgitation risk is greater with the Valsalva graft, and I've had to reoperate patients who've had Valsalva grafts, and over time the graft has stretched. I think we'll need better long-term data on that to see if that's the case, if it's confirmed what the Hanover group has seen. And there you see now the right-sided, or the right leaflet stitches being put through between those marking points, and then we'll feed that tube graft down around the valve. And there you see how we use tension on the commissures to also make sure that the hemostasis graft completely encloses the valve. Make sure there's no rim sticking out underneath it. And then the Haygar's is chosen by the patient's expected annular size for their BSA. So that's a description I wrote many years ago of the selection of Haygar's size. So anchor usually the 3 commissures first, and that's to make sure that you narrow your intercommissural angle. Otherwise you can end up with a leak at the commissures. So that's the first part where you gather up the annulus and reduce it to a normal size. Then once the commissures are anchored, I then usually tie down the sutures for the non-coronary commissure. Once you've done that, then tie down finally the right leaflet sutures. So here I'm marking more or less the height that the commissures are going to be, and I usually cut that piece of graft away. It's not going to be needed. You want as much tension, as I said earlier, on the commissures as possible. Then once you've done that, then now you can check the alignment of your commissures and making sure that the leaflet's going to come into good apposition. And there you can see it looks pretty good, maybe a bit more tension there on the left-right commissure. And then I mark that so I know more or less where it's going to be. As a general rule, the left non-coronary requires less tension. And I usually space those about 4 millimeters apart, so you create a bit of a sinotubular ridge when you eventually have completed this, and I think that's probably important for function of the leaflets. There's some evidence that that results in better hemodynamics. And then finally, the left-right commissure is anchored in position. And once you've got those in place, then you just use the running sutures to anchor it. I virtually always start with doing the left leaflet root annulus first. Be careful about not going too deep into the annulus. You don't want to retract the leaflets by going too close to the leaflets. I prefer to do a in and out method. It maybe takes slightly longer to do that rather than just a simple running over and over suture, but I think the precision is better with the in and out method. And usually it takes me about an hour to do a reimplantation operation. Once you get used to doing them, you should be quite efficient as far as doing the reimplantation operation. As you see, I leave quite a generous rim of the aorta to use for the reimplantation. That helps with hemostasis. It means also that the edge of that aorta doesn't end up sticking out underneath the graft, which is rather irritating when you find that you haven't got the whole aorta edge within the tube graft when after tying down the sutures for and around around the Hagars. So after the left cusp, I then do the non-coronary cusp. Sometimes you have to double back over the stitches here because the non-coronary may be very generous in the amount of tissue it has. Now at this point you've got the valve more or less anchored, and it's a good time to just check to make sure you've got good apposition of the leaflets, and you can see that they're lining up pretty nicely there. Again, make sure you don't go too deeply into the base of the leaflets and potentially retract the leaflets. On the right leaflet and its sinus, it's very helpful, particularly here in this area, to have a generous piece of aorta. There you see you're not going through the actual annulus in a sense, but just the edge of the annulus. And then finally, you're ready to tie down the sutures there for the commissures. Then you make the openings for the buttons. I used to at this stage test the root with antegrade quadriplegia administrator just to feel the tension. But now that I've become more experienced with these operations, I'm pretty confident in knowing just by looking at the valve if it's going to be competent or not. The other trick I used to use when I first started doing these operations is I would clamp the graft, give the antegrade quadriplegia into the root, but obviously not without the buttons attached, and ask the anesthesiologist to look on TEE if there was regurgitation. But once you've got your fingers educated to the amount of tension, particularly once you've hooked up the buttons, you can pretty well tell whether you're going to have a problem with regurgitation or not. And then that's the point where you look at the leaflets again and see if you need to put in some figure of 8 suspensory sutures to hitch up the leaflets. So there's that button. I leave always an upper edge untrimmed until this point, so I know I haven't rotated the button. That's usually not a problem in adults, but obviously in kids with the switches, that can be a problem, so you never want to end up with your buttons being rotated. Then I use Teflon donuts, and after a few hundred of these operations, I've never seen a button aneurysm, and I think the button is the key to making sure that the coronary artery ostium doesn't dilate. The other thing is don't go into the vessel itself, sew in the aorta. I start in the upper edge, in other words on the button, and then come into the button and then go through the Teflon donut around the button, and then do that back wall first. It's a very inferior back wall. Make sure your spacing is pretty tight on side and inside that coronary button, but make sure you're not inside the vessel itself. Then tuck that in so that you don't have a fold of the button, but rather that the button sits on the outside of the graft. Then usually I come up on the button for the left to about, I suppose it depends how you look at it, but about 3 o'clock position, and then go back to the other side to complete the rest of that anastomosis. Then same thing for the right, make sure there's no tension or constriction of the button, make sure you've got plenty of space. If there's a large coronal artery, there's a coronal artery as you can see here, and so one of the reasons to make that opening in the donut just a bit bigger. Again, you start on the upstream side, the outside in with your button, and inside out. Make sure you capture your Teflon. Initially I do the sutures fairly loose, and then later, shortly here, tighten them up. Make sure you tuck it in. Notice I'm also capturing the edge of the aorta inside the graft to just potentially improve the blood flow across those surface areas and less likelihood of having clots forming on the raw graft and tissue inside the aortic root. So just aligning that up, keeping going around there, capturing the inside tissue. And then the left to right anterior wall of that button. Making sure you don't oversew any coronal arteries. The EKG appearance, if you do, is apart from the V-tach and V-fib, is a Brugada type of syndrome EKG. So there you're ready with that button, just tie that down, and then we'll test this pressurized with antegrade quadriplegia administrator. Just check that that lines up nicely, looks good. So there's a Fogarty clamp, administrator inside, clamp that, and then I palpate that to feel the pressure. And that's a pretty good idea how competent the valve is. Once you're happy with that, then you do your distal anastomosis. I usually flush the ventricle in a sense with a retrograde quadriplegia at this stage and turn the LV vent off. So the graft inside the aorta here, because this patient's aorta is fairly normal size distally because it's a Loeys-Dietz patient, sometimes takes some tailoring of that 30mm tube graft to fit the distal aorta. Now we're doing the left side of that anastomosis. So there you have that unclamped aorta after de-airing here. I find it took me about 20-30 reimplantations to understand the nuances of the operation, and I hope just putting this video together will shorten your learning curve and how to do this operation. It's a very gratifying operation. The long-term results are really excellent with it, and as of nearly 2 years ago, we'd done 1,113 reimplantation operations. We tend to limit it to 2 of us who do most of them, and I haven't had a death from a reimplantation operation, so it can be very safely done if you plan it carefully, and the long-term results really look good, with now preliminary data looking like 97% freedom from reoperation at 10 years. And for example, for the connective tissue disorder patients, we've done 214 without a death, and the results are really looking good for that too. So we're in the process of updating our long-term follow-up, and we'll publish that hopefully quite soon. So thank you very much for your attention and looking at this. I hope you find it useful. Send me any comments or thoughts, and I hope this will help you to better take care of your patients.